right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined with Dr. Andrew Belis. Andrew, thank you for joining us tonight.
Well, thank you for having me. I appreciate it.
Yeah, so you're in an orthopedic group down in Florida, but let's walk it back for a minute, give people a little background. You went to school at Temple, you did residency in New York and Baltimore, but you've been in Florida now for quite a few years. How's the weather down there this winter?
We had a little cold spell and it's in the 60s now, but it's still better. I just came back from New York and it was in the 30s, so it's good to see the differences. Yeah, it's been good. That's why we moved down here, you know?
Yeah, I bet. Today in Iowa, five.
Oh,
Five. Wind
5
chill.
Celsius.
I don't know how to do the conversion anymore, but yeah, a negative 18 wind chill.
Oh
So
man,
brutal.
you can have it.
Yeah, it makes us appreciate spring that much more. You guys get so spoiled. You're like, yeah, it's a little chilly and then it warms up. We're like, no, we need it to warm up. Otherwise, we're going to lose our minds.
Oh yeah, oh yeah.
So you're in, yeah, go
Sometimes
ahead.
it's nice to open the windows, when it's a little cooler out.
For sure.
But when you're down here, your blood thins. So I do have to say that, sometimes we get spoiled and 75 sometimes is a little chilly.
Yeah. Well, you know what's interesting when it gets super cold here, when you have a 5-degree day, it doesn't take much of a warm up to feel amazing. If it gets to 34 tomorrow, there's going to be people in shorts. They're going to
Yeah,
love it. They're going to be
it's
like,
all
this is great.
relative. It's all
Yeah,
relative.
exactly. So you're in Fort Myers, beautiful
Yes.
place. I've been to Sanibel, Captiva many times. Beautiful area. What drew you? Are you from Florida originally? I think you're
No,
not from.
I'm actually from New York originally,
Yeah.
and I grew up in Long Island and went to school in Boston. But I actually couldn't wait to get out of New York. It was a little bit too intense, too crazy, too much traffic. Love the people. People are great, but it was just not my scene. So my folks had a place in Naples for quite a while, and we used to come down and visit in Naples. And I loved it down here. Come and vacation and say, hey, this is where I want to eventually practice if I could. And when I got married, I asked my wife, I said, do you want to live in the warm and visit cold? Do you want to live in the cold and visit warm? And she said, no, we're going to Florida. So Florida had a great scope of practice as well, which would allow me to use, kind of my training. And so it was a little weird at first because I felt a little bit like an outsider. I didn't do any training in Florida.
Mhm.
Most of it, I was kind of this outsider coming in, but the people in Florida and my colleagues are very welcoming, and it was an amazing experience. And then when I came down here in 2001, 2002. I joined a private practice, a podiatrist, and we worked together for quite some time, about 6 years, and partnered into that. We had plans on expanding. It didn't quite work out that way, and I ended up deciding to move outside of my restrictive covenant to Fort Myers because we were in Cape Coral,
Mhm.
and then joined the orthopedic group. They were kind of courting me a little bit, and it was a perfect opportunity. I was able to use the fullest extent of my scope and my experience, and then joined the group. They were an amazing group of people. I've never met orthopedic physicians who were this open-minded, welcoming to podiatrists joining their practice, and they really treated me like an equal. So it was a very unique situation. You don't always get that, but it was a very, very good experience as well. And quickly thereafter, I partnered in as an equal partner, and it's just been great ever since.
Let's take a second to dive a little deeper into that and talk about the pros and cons of private practice versus an orthopedic group. Orthopedic group is the apple of most young students, young residents' eye. And I've worked in an orthopedic group and it was great and left for family moving reasons, not because I didn't like it. But what would you say are the pros and cons of private practice, but then orthopedic group on both sides of the coin?
Well, I think if you're in a private practice with another podiatrist or all podiatry practice, I think you have a lot of commonality as far as the types of procedures that you do. And I think you have a lot of commonality of, how you can distribute revenue coming in. Sometimes the overhead tends to be a little lower as well. There's not as robust of a
Mm-hmm.
background and there's not a need for as many support staff. We're pretty efficient as podiatrists, I think. And actually was making good money there. It's just that the exposure to different opportunities were not as great. When I came to the orthopedic group here, the overhead was significantly higher. The revenue was a little bit higher, not as much as everybody talks about as
Mm-hmm.
far as reimbursement, but technically we had more opportunities, surgical centers. We had more options for ancillaries to support the business for that, and it was just a little bit of a more diverse group. So you got to experience the different specialties and what each of the concerns were. So grass is not always greener, but at the same point,
Yeah.
I think the opportunities were more, and so that allowed me to, experience the different opportunities to maximize revenue that way.
What about the idea that in private practice, you're essentially competing with your partner? Like only one of you can get a new patient. And if you join an orthopedic group, depends on if they have competing specialty or another podiatrist. But did that ever factor into your thinking of saying, hey, if a patient comes in, I'm actually competing with this person versus if I join the orthopedic group, they're going to feed me all the business. Does that factor in or not really?
Well, I think it always factors in. I think when I was at the podiatry two-man group, as an associate, I got a little bit concerned about, making sure I got enough business. And I tended to be more the surgical podiatrist, and he was more the conservative care. So it was a good complementary thing. He would send me patients. And when I joined the orthopedic group, I was more of the go-to guy. I was the guy for foot and ankle. So I would get everything. And then as we grew, we added more. There was so much business, podiatry wise and foot and ankle wise, that uh, I was a little hesitant to recommend hiring another physician or getting a new doc on board. But after doing it, I realized it was more complementary and not taking away business, because the point is to get the patients in the door, to capture the business as far as the practice as a whole. And you have to have a different mentality. You kind of have to have good for the group mentality. And
Mm-hmm.
because of that, I think it allowed for both of us to do better. And currently, we have several podiatrists at our group because it worked out that well. We have a couple of more conservative care podiatrists who don't do the quite as much surgery as we do, and the diversity of cases that we do. And it's been very nice because a lot of times I can refer some of those cases, those conservative care to her and him, and then vice versa. They send it my way as well, the surgical cases. So it's actually been the opposite of what I thought. It was actually complementary, and it added to overall revenue and overall business. So it
Sure.
allowed me to subspecialize a little bit more.
Yeah, absolutely. So you also serve as a fellowship director at OCF, the Orthopedic Center of Florida, since 2007. So kind of talk about your experience of how you started the fellowship and what it's been like so far, and then we'll kind of lead into what the fellow could expect if they were to come join you. So talk about how you kind of got interested in starting a fellowship almost, 8 years ago.
Yeah, it was a labor of love a little bit. I think I was getting such great pathology. I was getting great experience at this. I was getting treated as an equal, and it was a very, very good, positive experience in a multi-specialty orthopedic group. The cases that I was getting were diverse. They were lots of trauma, lots of sports medicine, lots of reconstruction, and I wanted to share it with somebody. I wanted some like a partner to kind of show what we're doing and be able to share educational things that we were about. So I went to my partners and I said, "Hey, listen, I want to do this fellowship. I think it would be nice to have a helper in the OR. In the state of Florida, podiatrists cannot oversee PAs.
Mm-hmm.
So in this case, it was coincidentally beneficial there as well, because he could help me out, and I didn't want to abuse it. I wanted truly a fellow to kind of educate and have him as almost like a mini attending, so to speak. And
Sure.
that way they can get the fine tune their skill set, as well as help out with OR and all these things. So I went to my partners and I said, "Hey, listen, I'd like to do this," and they were a little skeptical. I got it going within several months, and we got conditional application through ACFAS
Mm-hmm.
and our approval. And then we started off running, and it worked out really well. We've now had seven or eight actually now fellows, and it's been a great experience. And I've grown as a mentor as well. At first, I was trying to be very overly helpful, and kind of you learn to see what they need, and each fellow needs something a little different, whether it's psychological or emotional or how the practice works. And
Mm-hmm.
some need certain aspects of surgical experience, some need others, but it's been great.
Yeah. Walk us through an average day in an orthopedic group. Let's not even say average day. Let's do an average week. How much time are you kind of in the office and surgery and call and talk about all that stuff? Kind of like your daily expectation for what happens on any given day of the week.
Yeah, so I think just the type of I think you kind of mentioned like what is an orthopedic group. I think we still have a foot and ankle care group at our practice. We have like kind of a whole floor that we see patients on. But you're right though, the orthopedic nature of the practice does lean towards certain types of pathology that come in and patients expect it, and our partners usually send more of the orthopedically oriented cases our way. Now, with that being said, my typical week or day, usually I'm in the operating room 2 times a week, usually on Wednesdays and Fridays. We're in clinic on Monday, Tuesdays, and Thursdays. And on one day of the month, I'm not in surgery on one of the days, so we open up clinic if we can. Usually, we are in clinic from 8 till 11, or excuse me, 12, and then from 1 till 4ish. Usually, we're seeing patients every 10 or 15 minutes or so. I'm not we don't pump them out. I do try to give good care. I tend to talk a lot to my patients, and I think they appreciate it, even if I run behind. We have really good Google reviews, and I think it's because we do care about our patients. And we
Hmm.
do see a combo of patients. We see some conservative care. We see, some diabetic patients with neuropathy, and we see, some occasional nail care patients. But, a lot of that stuff I offer to our non-surgical podiatrist, and sometimes patients say, "Hey, I've been with you forever. I'd love for you to keep being my guy." And
Hmm.
we kind of honor those types of things. And other
Yeah.
times it's different. But we get a lot of trauma, and we get a lot of sports medicine, ankle injuries, ankle instability. We get a lot of bunions. We have, interestingly, we in Florida, in Southwest Florida, where we live, we get a lot of the older population, and things that I used to never operate on. I'm finding like tends to be the norm now. And these patients, although they are older, they tend to be younger, in appearance and in functionality.
Hmm.
I don't know what the age group that you see, but a lot of the retirees down where we are actually, I guess the 70 is the new 55 or 60, so the people I'm operating on now, I would, 20 years ago, I would not even think about, but I think it's been an evolving patient population. And so usually the way we work with our fellow is I see patients on my clinic days. He or she would see patients concomitantly with me. We give them opportunity to work with both with myself during my surgery days, as well as with our other attendings. We have another fellowship trained surgeon that's our group. And so usually he's working 2 half days a week, and our fellow works with them.
Hmm.
There's a new podiatrist who does wound care at the hospital. He was a fellowship director up in the New England area, and he's there once a week. So we have a half day that we give the fellow, like a flex day, to do the OR stuff on his own. If he's on call at the hospital and he admits on his own, usually he's
Hmm.
doing like amps and some minor traumas. If he gets a trauma that he doesn't feel comfortable with, I would help assist him with. But it's kind of like a mini attending, and anything he can't handle, we're certainly there as backup. Now, because we're in clinic, similarly days, we also run cases by each other. He usually does the pre-ops and the post-ops. I'll certainly pop my head in and make sure everything's doing okay. But that gives him a chance to work up the patient preoperatively, run through the pathology, make sure that the procedure selection is appropriate and we didn't miss anything, and then he'll see the patients and assist with the surgery, and then do the post-op care. And I think that's a big part of why I did this, is because I don't think a lot of the residents get experiencing all of the post-op care as an outpatient thing.
Yeah.
So that part is tricky because every patient has a little different post-op care. I'm sure you know that.
Yeah, absolutely. I think that's one of the bigger limitations of residency, some residencies, is we were a little spoiled in the way that we did it when I was in residency, but we would be with a certain attending for a month or two at a time. What that allowed was for pre-op workup, OR, post-op follow-up with the same patients. It didn't always work out if we came on or left service during that time, but it allowed for kind of some transition of care. I think a lot of times when people bounce around, oh, I'm on surgery, I go here, here, here. Well, you don't know how to work up a patient. You don't know how to manage these post-operative infections, wound dehiscence. Is it normal? Is it abnormal? Do we need to do something? Do we need to not do something? That's the most complicated part of what we do. I think sometimes people think that the surgery is the hard part. The surgery's never been the hard part. Surgery, I could teach whoever to do surgery. That part is very regimented, like do this, do this, do this, do this. But it's the using your brain that, surgery can get complicated if it doesn't go quite according to plan. You have to move to plan B, plan C, whatever it may be. Don't get me wrong. But in the office, that's where people are, hey, I'm having some numbness right here. Like, oh boy. All right, well, let's see. Is that okay? Can you feel, when you say numbness, do you mean pins and needles? Because that could be from swelling. Or are you talking like you can't feel? Oh, it's pins and needles. Managing these patients is kind of the next level beyond just understanding how to do the surgery. So I think that provides really good experience, like you said, a mini attending of getting that experience, especially for someone who was in residency, which I think it's very common to not get very much pre-op workup, post-op workup, and they're either just in clinic seeing patients or more likely just in the OR a lot of their time.
Yeah, I agree. And I think that the even just setting expectations about, hey, this is what should be normal, this is what should not be. And then also breaking molds, breaking the mold of what these residents have in their head as far as what they should be doing post-op. A lot of times as we see a lot of the diabetics and the neuropathics, and we're always driven into our head, hey, you got to be really careful. You got to prolong immobilization, you got to prolong care. Well, when you start doing more elective cases and more sports cases and other, forefoot and rear foot, recons, pushing the envelope and getting these patients back quicker, that might
Mm-hmm.
be the better solution. If the patient's having post-op nerve pain, I tell them, listen, you have to push through this. That nerve's never going to wake up unless you start using it, unless you do the therapy, and that's
Mm-hmm.
a hard thing to push to somebody because we all are super protective of our patients. We don't want anything wrong to happen or bad to happen. So those are
Mm-hmm.
just some little examples of the things we try to instill and then early ambulation afterwards. I think we're taught as residents to just immobilize everything forever. And I think that's not always the right call, especially with some of the more modern techniques that are out there, the MIS techniques and things like that.
Yeah, I agree with you. I think there's always going to be generational shifts, and I think we're in the midst of one with MIS and becoming minimally invasive, and we're probably going to beat that term to death and just kind of talk about it until our faces turn blue. But it does, I have seen, change post-op protocol. When you are used to doing X number of weeks non-weight bearing, and all of a sudden you're doing an MIS approach, and they're like, yeah, it doesn't really hurt. When can I walk on this? You're like, oh, okay, yeah, I guess we're going to maybe advance you a little sooner than what we used to tell people. So I think being adaptive is also, like you said, important. Understanding that no two patients are the same. Even if you do the same surgery, the foot attached to the patient that you did surgery on is attached to a different patient, and you need to be able to adapt and understand those things. So I think that's a good skill.
Yeah, I mean, even if you think about trauma and elderly people who we have a lot down here, I mean, to expect a 90-year-old who happen to have a really bad displaced fracture, even though they have good blood flow, they might be okay. I mean, to expect them to stay non-weight bearing is just it's really difficult to
Yeah.
expect that. So at least adapt your fixation or adapt your construct to be sturdier so that you can ambulate these people. 1 week immobilization of a 90-year-old is like a month for me or you.
Yeah.
So you just have to think of the bigger the person and not just the fracture that you're looking at.
Yeah. I tell my elderly patients all the time, if I put you in this boot and you tip over and you break a hip, a wrist, or hit your head or something, I've created a much worse problem than what we started with. Like, I'm not going to be the one that said, "Oh yeah, don't walk on this," and I got a 90-year-old on a knee scooter or something. Like, I let them walk way sooner just because I know they're going to, number one, follow instruction. Number two, they're going to limit their own activity to their tolerance. And number three, I don't want to cause a bigger issue than what they came in with.
Exactly.
I think it's interesting you said that you do OR days on Wednesday and Friday. My OR day is Wednesday. And I've always thought, that you kind of start a new job and you think, okay, well, what's the best day of the week to do surgery on and why? And you can kind of talk yourself into why one day of the week is better than the others. I've always thought that maybe Friday, and you can correct me, you can throw in your own 2 cents. Friday wasn't the best day because if someone was going to have a problem the next day, well, if I'm on a Wednesday, I'm in the office on a Thursday, I can handle that problem. But on Friday, there's no one in the office on a Saturday. What are your thoughts on best operative day? And do you particularly plan, okay, well, you're going to be a Wednesday and you're going to be a Friday because of the type of cases, or do you not think about that or seem to have any issues?
Well, I think it's evolved to those days. Initially, I was doing Tuesday and Thursdays. I think the other thing is I do a majority of my work nowadays at the surgical center, and so
Hmm.
I use the days that they have available. And they've actually, I'm one of the busier guys at that surgical center, so they kind of adapted certain days for me, and
Hmm.
so I kind of have them saved. I used to think it was going to be a problem being on a Friday, but I think, listen, if you think about post-op infection, usually it takes 2 to 3 days for that to kick in. And so really infection-wise, there's not an issue. Pain, you get some pain control, but you learn how to really preemptively manage that. And I think I started working on Fridays when I had a fellow so they could take call and they could listen to the complaints.
There you go.
No, I'm just teasing. But no, I don't really think about it any differently between a Wednesday or a Friday. I think the nice thing on a Friday is if you have a little shorter day or a little less patience, you got a little bit more time on the weekends. If you the Wednesdays, sometimes if it's a shorter day, you can have an afternoon, office or something like that. But for me, I usually we see people back 5 to 7 days later.
Hmm.
And it's because my thinking is 5 days minimum before infection kicks in. If it's going to be infected, you're already preemptively giving them prophylactic antibiotics. And by the time you do the dressing change, let everything calm down. If it is a little red, then we can restart them back on an oral antibiotic.
Hmm.
Also, you need to get them through that first couple of days. Everyone's going to have a little bit of pain depending on what you do for 2 days minimum. So, sometimes you got to walk them through on the phone. You had to give them some options, loosen the back. So I don't have a problem being available on a weekend
Hmm.
to answer calls. But I mean, technically, I mean, there's the emergency room. That's there for those reasons. So not that I rely upon that, not that we have a lot of that, but I think it's worked out well for me because it's consistent, and I've got the whole day block time if I need it.
Yeah, makes sense. Let's talk for a minute about your involvement with the Florida Podiatric Medical Association. You are past president
Hmm.
of the, what is it, FPMA? Is that what you
Yep.
call it? So talk about your involvement with them and what role they serve in your state, and if any issues come up, how you guys kind of tackle those.
Yeah, yeah. I didn't originally think I was going to be involved with that. I became involved in our little component of our county, and I really started liking that. That got me up to the state level and at least, showing them what we're doing as a county. I think I did a really good job compared to what was going on before me, and so then I became the secretary and I worked my way through the ranks, and it was just a great group of people from all over the state. Surprisingly, I really enjoyed it a lot, and I just kept getting more and more entrenched in it. And it was just like a big family, and there was no competition. It was really everybody was trying to make the profession better from a state standpoint. So I really
Hmm.
enjoyed that part of it. And we are one of the biggest. Well, we are the biggest state now as far as members, and so it's a big state. So it was a little bit, a little scary thought to be involved, but going through the presidency was just a really good experience. I think we had good support, we had great administration, and it got us involved with the APMA as well. Our representation there. The thing is, we do a great meeting at our state level. We do the SAM meeting. I don't know if you've ever been there. It's called the Science and Management, or
Hmm.
SAM. And
Hmm.
I'm on the convention committee now. So we do a lot of the program. I do a little bit more of the surgical aspect. Dr. Frimmel's, kind of the main doc that's in charge of that as well. Dr. Frisch as well. But Dr. Frimmel and I do the scheduling, the speakers, and things of that nature. And we kind of pass back and forth, the kind of creation of events. But it's a team effort. We have a big team that does that. And it's been great because you get to know who's lecturing in the area. You get to see, involvement with our state society. The cool thing is that it's part of our dues. So when you pay your dues, and you're a full member, you get to be coming to these meetings for free, and you get a lot of the credits that you need. And they're fun. The meetings are fun. It's definitely less stressful than operating or doing something like that, and sharing ideas with colleagues. When there
Yeah.
are problems, it is good for handling issues from an insurance standpoint, as well as because we have a group of people that are very knowledgeable about that and that can help with lobbying our state legislature. So it's been a good experience, and I made a lot of good friends accordingly.
Yeah, absolutely. What is the biggest role of a state association? I should know. My wife is on the state association here in Iowa. All I know is, hey, I have a meeting tonight. Okay, I'm gonna take the kids and go play video games. But I'm kind of joking, but what is the biggest role for a state association? Is it the betterment of the profession? Are you handling internal issues within certain providers, or what are the main things that your role is in that organization?
So I think each state has its own problems, has its own issues. Our mantra is, or at least the state is, in my opinion, is there. Number one, it supports camaraderie and it helps bring everybody to the table to share ideas and to share concerns. And if there's a problem, we can help try to figure that out. We have a legal representation that can help advise with certain conditions and certain problems. They can help with disputes. We have an ethics committee that we deals with. I was part of that at one point. They involve with education and providing, the CECHs for keeping your licensure up. They help keep our state scope of practice strong. It helps us communicate with other state specialties like the FOMA, the Florida Osteopathic Group, and other groups accordingly. I think the biggest thing is it helps us collaborate our ideas to help accomplish, and better podiatrists in the state of Florida. I know it
Sure.
sounds very cheesy, but it really does try to achieve all those.
Sure, absolutely. I think it's very important. I think some people neglect the importance of overarching organizations that have our best interest in mind, whether it be the APMA or on the state level. So all of
Yeah,
those
and we're
are,
stronger together. I mean, let's face it, if we can act together as a team, we're going to accomplish more than if we try to, fight things on our own.
yeah, absolutely. I agree. What do you think about hopping into some cases here? These are cases that you have performed. So I'll let you kind of explain what's going on here with this first case.
Yeah, so this is an interesting lady. She lived in Naples and was transported to our level two hospital. And she's 57 years old. She was riding a bike. She only knows how to ride bikes. She doesn't have a car or anything. And she was riding, and she got hit by a motor vehicle, and she was pinned underneath the car, and they kept dragging her
Ugh.
many hundreds of feet, I think, or at least 100 feet or so.
Ugh.
She was triaged and in the ER, and they contacted me, and I kind of saw that this patient had this big open laceration. There was exposed bone. We were concerned about some arterial issues. Obviously, there's loss of skin, and just looks nasty.
Yeah, big open fracture over the medial aspect, large defect over the medial malleolus and down the medial side of the foot, extending all the way to the first metatarsal head. So, nasty open injury here.
Yeah. So obviously, it was Agustillo Anderson type 3B with the open fracture. Luckily, she had pedal pulses. She did have actually gravel in the wound, and it was like grinding away at her medial malleolus. So when you look at her x-rays, you can see that her medial mal is basically filed down from the
Yeah,
floor. It's nasty.
that's crazy.
Yeah, yeah, yeah. It was pretty bad. So that was a big concern because, there was very little left of the medial malleolus.
Yeah, that's tough. I had a guy here in Iowa one time who stuck his foot into a hay baler and it just shaved off the entire medial side of his foot. So, not too
Ouch.
dissimilar from this, but yeah,
Yeah.
nasty injuries.
So obviously we get X-rays higher up, and the first rule is to kind of stabilize this guy and this lady, excuse me, and flush it out, clean it out,
Hmm.
and kind of obviously we're looking at a staged approach here. Oh, there it is. I gave it away.
Yeah.
So we put her in X-Fix just to stabilize the ankle. We flushed it out, washed it out, took out any of the gravel pieces. A lot of it was embedded into the bone, so we had to kind of scrape some of the bone as well. We were able to flush it out aggressively and kind of primarily close a small amount of it, at least as best we could, to at least get some soft tissue coverage over the area there.
Yeah, so
Obviously, we had to flush out the joint too.
right, modified delta frame here with pins in the calcaneus, two half pins in the anterior tibia, and then a pin in the first metatarsal to stabilize that construct. So,
Yeah,
yeah,
I think if you don't stabilize that forefoot, you might get a flexure contracture. So those are, keeping it as close to 90 as possible, I think is helpful if they can.
yeah. And so this is kind of an urgent slash emergent. I know in our
Yeah.
profession we call things emergent, but then other things like open head trauma and strokes are actual emergencies. But this is as emergent as it gets for us, is going to the OR straight away and stabilizing, washing.
Yeah. And then I put a wound vac. I don't think I showed that on that picture, but I put a wound vac on there as well.
Yeah, so wound vac over the medial wounds, but yeah, now you're left with no medial malleolus. Just
Yeah.
it almost looked.
Unfortunately, there was
Yeah,
very
go ahead.
little left and it was nasty and necrotic and there was no periosteum attached to it. There was a little discussion. Do we leave a little piece of it left? Do we not? At this point, I wanted to make sure we just got rid of anything that was problematic.
I was gonna say, I think you're probably begging for problems if you're gonna leave any kind of comminuted infected bone behind, or most likely infected bone behind. That's gonna cause problems for you in the future.
Right, right, right. So anyway, we staged her. We continue to watch her wound and her skin. We were wound vaccing her as well, and started to close up a little bit. Luckily, she didn't get any infection at that point in time. And she also had like that maceration and like abrasions to the skin around the area that we closed as well. So that added a little bit more challenge.
What are your thoughts about a delta frame like this that allows them to rest their leg on the ground versus a delta frame that kind of creates like a tripod effect? What are your thoughts on pros and cons between those things, kind of offloading, or do you just want to get this thing stable and you don't really think about that or care?
I think at the time, this patient, like she wasn't neuropathic, she didn't have diabetes, and really it was just an isolated trauma. She
Hmm.
had no wounds on the back of her calf. I mean, I usually would do that if I'm concerned about a pressure sore developing.
Hmm.
At my hospital, they don't allow for frames right off the bat. This was really the only construct that was available on the in the operating room at the time.
Yeah. No, it makes sense. I think it looks good. So sometimes people do like a more triangular construct and try to elevate it off the ground. But I
Yeah,
think this looks great.
I think I would have done that if I was concerned about a pressure sore developing or something of that nature. But she was pretty sensate to the posterior aspect of the leg.
Sure.
So we did a repeat debridement after that, and she was starting to have some tissue coverage capabilities. So we added a integragraft and kind of flushed her out again. We kept with the external fixator, I think, at this point.
Hmm.
Really, this goal was to try to get the wound closed and get everything healed up, and then we would figure out what to do at that point. So the wound was coming around okay. There was some suspicion of like a subgraft hematoma. It was a little black and blue, but turned out that was a little bit more of the granulation underneath there.
Yeah.
So this is just an evolution of the pictures of her healing.
Hmm.
You can see on the picture on the left, it's a little bit suspicious of healing, and then over time, after we cleaned up some of that superficial area, there was some good granulation tissue there. So it gave us a good scaffolding for the deeper tissues to fill in. And sometimes, even if you have to stage these graphs, over and over again to fill in the depth, it's sometimes something we've done before.
What do you put over these graphs? Are you putting on a non-adherent? Or are you vacuuming it, or what
I
are you
think I
doing?
was vacuuming it again. I
Yeah.
think I vacked it each time we did that. Yeah,
I can. It kind of looks like that with that hypergranular tissue in the center of that picture on the right. It kind
Mhm.
of looks like you'd been wound vacuuming it and kind of bringing up a lot of that tissue to the surface.
Exactly, exactly. So you can see here that we're seeing more and more granulation tissue. The hard part was that there was also that abrasion next to it, which was more partial thickness, full thickness type tissue, but it was coming around okay as well.
I think what's interesting about pictures like these is that I think most people, if they saw this, they would be horrified. And you and I look at this and are like, "Oh, look, it's healing. Look at that. It's
Hmm.
progressing. It's doing well." It's just interesting what you're used to looking at and what
Yeah,
you're
and one thing
expecting.
I'll say with these is that sometimes you look at that yellow area and you're like, oh, it's not surviving, but
Hmm.
sometimes it just takes a little more time for a thicker graft to absorb. And I think docs and we're sometimes taught to debride everything very quickly, and sometimes you got to let it continue to evolve and continue to act as that scaffolding. Now, when it turns necrotic, obviously you can remove it, but
Yeah.
I think that's another key with these acellular grafts. So you see,
Yeah.
it's looking really good here. We're getting some more and more granulation tissue, and
Hmm.
we're continue to evolve here. You can see the dates there. So at this point, I think it was ready for a split thickness skin graft. My threshold for those are low. Usually we get them from the thigh. In the state of
Hmm.
Florida, we're able to do that. Every
Yeah.
state's a little different. So I think it turned out pretty good here. I think that was her application. We took the X-Fix off at this point in time, kept
So
her non-wavering.
harvesting, meshing, and then skin graft application.
Yes, and there should be a picture of the donor site shortly, but you can see as the skin graft evolves, we're doing some non-adherent dressings,
Hmm.
and it's just continuing to evolve. And again, sometimes your temptation is to debride everything too much. I think, some non-selective debridement is sufficient, but I wouldn't go too crazy with these. Sometimes they still have to act as scaffolding.
Especially in a sensate patient, they're not going to be your friend if you keep scraping this thing. They don't like that. That
Hmm.
hurts.
And you can see it's evolving nicely and it's filling in, and
Yeah.
it's coming along nicely. Now that we've got the skin closed, now we're worried about what do we do with this ankle. Luckily, it hasn't kind of shifted out of place. So what do you think, Jeff? What would you do?
I think your only option is fusion. I think, if you were going to try to consider anything else, the lack of a medial malleolus is going to prohibit you from consideration of, ankle
I thought you would
replacement.
do like a 3D medial malleolus, Jeff. No?
Now you're thinking outside the box. I like that. 3D printed medial malleolus with a couple holes, fire some screws up into the medial tibia. Yeah, I mean,
Well,
sure,
the
why
only
not?
problem
So,
with that is that there's no tissue there. There's
yeah,
no soft tissue. So
I was
yeah.
going to say, someone's
Yeah.
got to be the first one to try that. But yeah, for anyone just listening, we're just picture just a complete vertical shear medial malleolus fracture, but then take that entire piece out. So it's almost like the medial aspect of the tibia comes straight down into the medial talar shoulder. There's even a little uncovering of the medial talar shoulder due to lack of a tibial plafond there. So just very, very limited in terms of structural support on the medial side. So no deltoid, no medial malleolus, no medial buttress effect of the medial malleolus. It's just going to be very unstable with anything but an ankle fusion in my mind. Were you considering anything but fusion very seriously?
No, I think the plan all along was a fusion, and she was not liking that because she's a biker and she wants some motion in her ankle, and she's a little cray cray. But
I was going to say, you got to put
she,
this in perspective. You're
yeah, yeah,
lucky to
no,
have your leg here. What are you
exactly,
getting picky
exactly.
for?
The funniest part is that was very stable, believe it or not. You'd think it'd dislocate easily. It,
Yeah.
it actually was very stable. I think she was even doing a little partial weight bearing on it and not having a
In-
lot of pain. It was pretty funny.
interesting.
So anyway,
Interesting.
we decided to go fusion with her, but obviously because that huge graft medially and with the compromised tissue, we end up going with an arthroscopic ankle fusion,
Yeah.
which I think there's a lot of studies that show that they do better anyway, and they have less swelling, quicker healing. And we did our three screw construct here.
You going two portals anteriors, like standard portals for this?
So yes, standard portals. I go just medial to the medial malleolus. I'm sorry, medial tibialis anterior, excuse me, and
Hmm.
just lateral to the EDL, and avoiding obviously the SPN nerve.
I was gonna say, if you're going off of medial malleolus here, you're gonna be confused.
Yeah.
Now where do
So
I go?
yeah, we just kind of stayed as far away from that skin graft as we could,
Yeah,
and I think it turned out really well. And this
yeah.
is just immediately post-op. You can barely see the joint, and it turned out it was in good positioning. We were happy with the repair, and
Hmm.
kind of kept things minimal incision.
Yeah, absolutely.
So those are our portal sites. You can see a couple of portals, one medially, two medially, excuse me, and two laterally, one for the screw and one for the portal site, and then one percutaneous puncture site, I believe, on the lateral side. The, the portals, I mean, the one are for the portals and the others are for the screws. And that's post-op. You can see very little swelling. And
Yeah,
then she's progressing very nicely here. We wanted to be careful for that medial side.
yeah. I like that kind of elongated screw more into the talar neck to provide some additional stability there. Sometimes it feels like you start to run out of real estate to get that third screw across the tibio-talar joint. So I kind of like that angulated screw a little more anteriorly to kind of free up a little bit more space in the talar body.
Yeah, you just kind of come a little more, posterior to the tibia and then kind of angle it that way. I think that was really helpful.
Hmm. So are you, obviously those are cannulated screws, so you're getting your alignment. Are you typically aligning tibial crest with second metatarsal, or what are some kind of intraoperative tricks that you're using to make sure that you're fusing the ankle in optimal alignment?
Yeah, I think this was an easy one because the ankle was pretty much in neutral alignment already, and we didn't have to worry about that. But obviously, when you take down the joint, there's a little more play.
Mm-hmm.
We do look for. I do keep that thing we're taught, which is that second ray or second parallel to the anterior tibial tubercle.
Mm-hmm.
I do want to get that the talus body, centered and a little more posterior on the ankle. I think people too much, especially if you're doing it arthroscopically, you don't go posterior enough with your debridement, and so the talus is more anterior on the tibia. You got to really make sure that you posteriorly displace it a little bit more, and that way it sits neutrally, and you keep your pivoting effect there going.
Especially, you got to be careful if the foot is laying on the table and you destabilize the ankle because you've taken off all of the cartilage. You can picture that the table pushing the heel would want to slide tibio-talar joint anteriorly. So you just got to be aware of that, or let the heel offload on some sort of elevation so that the table itself is not causing anterior translation.
Yeah, and one more little trick with that arthroscopic approach. Usually I use a 4-0 burr. They're a little bigger. You get things done quicker. Too many times I've seen people reach for the smaller burr, and it's going to, you're going to be in there forever. And
Yeah,
then that also provides a better, lavage and irrigation of all the debris from in there when you're using the larger scopes. And then
sure.
this distraction is really important. You want to make sure you get good distraction effects. And there's some techniques that we use to help with that. We use the foot of the table to stretch it out.
Yeah, mostly
So
so you can get all the way to the posterior aspect of the joint in that
correct.
case, correct?
Correct. These are just x-rays showing graduated healing and graduated consolidation of the fusion site.
Mm-hmm.
She's at 9 weeks there and it was doing really, really well. She started putting some weight bearing on it at that point.
Okay, I
And
was
this
gonna
is
say, when do
about,
you let her walk on it?
yeah, I think once I start to see some bone consolidation, I'll do some light touch and ambulation. Usually 4 to 6 weeks on average. I start letting them do some partial weight bearing. I'm
Mm-hmm.
very aggressive with these, unless they're obese, unless they're neuropathic. I try to get them a little bit of touchdown weight for just to stimulate some healing.
Are you augmenting with any graft on your primary fusions?
Nowadays, I am. To be honest with you, this is a little older case, and I can't remember if I did that with her on this particular case.
Mm-hmm.
I think I may not have because of this in situ nature, and she was pretty healthy, not a lot of medical issues, and I didn't feel like I don't think I did that in this case.
Yeah, this looks great.
Yeah, but a
Good
lot of
alignment.
times I'll do either I'll harvest some bone marrow aspirate and I'll do some BMA or some other type of supplemental implantation just to fill the nooks and crannies of these areas.
Mm-hmm.
And I might have done it in this case, and I apologize that I don't have the app for it here
No, you're
to
good.
refresh my memory on this one.
No, I just not necessarily on
But
this one, just
usually I
in
do.
general, just kind of your thought process behind.
Yeah.
It's I struggle sometimes because I don't see a big downside of augmenting with something. I don't even care if it's autologous bone graft or something that the patient's already has readily available and not infinite. I was going to say infinite supply, but quite a bit of extra bone graft to put in there. Because if you ever do get a non-union and you didn't supplement it with something, you sure wish that you would have supplemented it with something. So you kind of do enough cases, you get a couple non-unions, and you just start throwing as much as you can at the primary, so you don't have to do revisional surgery.
I think for me, it's hard to make two curved surfaces on a joint that is done arthroscopically. So the way I look at it is I'm putting it in. If I need biology, then I'll add biology. If
Mm-hmm.
I need filler and scaffolding, then I'll use an implantation, an injection. I think I may have used some BMA for this. Anyway, you inject that into the joint. It kind of helps fill the nooks and crannies to
Mm-hmm.
kind of fill the areas that you may have missed with the scope debridement technique.
Yeah, absolutely. So,
Anyway, she came in. That's what reminded me about this case is she just came in this past week and she started getting a little bit of posterior subtalar joint pain. And in my practice, we have access to a C-arm, so we do fluoroscopic arthrograms, and we ended up doing an injection back here. She had complete relief of pain. You can see that the posterior talus got a little bit hypertrophic. So I think the next she came back again. She had good relief, but then it came back, and so I think the next step might be a posterior posterior subtalar joint arthroscopy, remove
Hmm.
the hypertrophic bone, get that joint being able to move a little bit better, and remove any further impingement to buy more life back to the subtalar joint, which we all know after an ankle fusion can start to get beat up and become arthritic.
Yeah, difficulty level of a subtalar joint arthroscopy goes up considerably. So what are your standard portals for your STJ scope?
So I usually go medial and lateral to the Achilles, obviously, and
Hmm.
we try to be at the level of the malleoli inferiorly, and that way you can kind of scope up a little bit or just more parallel.
Hmm.
Usually, if you're doing a posterior ankle, you want to be a little bit low and go high. You can access the posterior joint that way. It is harder because when you get back there, there's not an easy joint to see. You have to kind of create a space. It's almost like you create a space and then you look, and then you create a space and you look, and then you see your ligaments, and then you debride that, and then you see the joint space and clear lines, and then you can kind of start working from that space forward. You just have to be careful of the FHL tendon.
Hmm. Are you trying to excise the posterior talar hypertrophy through the scope, or are you going to open that? Because that's a pretty big chunk of bone there.
I think if it's bone, if it's attached, it's hard to see specifically. I don't have a CT as of yet, but usually
Hmm.
if it's just a spur, you can debride it with the 4 shaver.
Hmm.
Sometimes if you can loosen it up, you can, open up your portal sites and take it out accordingly. But really, I look for intraoperative movement and seeing if there's any further impingement there and what's irritating it. So if you cavitate around it and you leave a little section left over, who cares as long as there's no impingement back there?
Hmm. Yeah, I think this is a great save. Apparently, she's not overly appreciative, but this is a
No,
great
she is.
save.
She's actually, I'll tell you, she's very appreciative. It was
Good.
just a comment she made in passing, the other thing I mentioned. But the funny thing is, I told her, I said, listen, we have a we have a new office down in Naples. You should go down there. It's an hour and a half to get here
Hmm.
by buses that she takes. And
Mm.
she's like, no, no, I'm coming to see you. You're my man. And so she'll take the hour and a half bus ride to come up and see us. So I think she is very appreciative.
That happens to me too, and I'm like, "Are you sure?" There's lots of other people. No, you're my guy. I don't know. I don't know if I am. Maybe there's someone else who might be better for you.
Yeah, yeah. You're the man, Jeff. You're the man.
apparently, apparently. All right, let's jump ahead to this other case here.
All right. So this was how old was she? I forget.
17 is what it
17
said.
was it? Yeah, 17-year-old female lacrosse player. And she had a right ankle pain. She mostly had pain to the anterior aspect of the ankle. It started about 3 months ago. She had no prior injuries to that ankle before this. She had intermittent mild pain. She had a popping sensation. She had tingling of the foot and no numbness. Her pain was about 5 out of 10. And activity obviously exacerbated it. And she states she didn't feel too much instability, although when we examined her, we saw some different things. We did an MRI for her because, athletic and wanted to see what was going on here, and her insurance allowed for that. She had good range of motion at the ankle. She did have some crepitus with range of motion of the ankle, and she did have a positive anterior draw that was pretty severe, mild pain to the anterior and posterior ankles, and good muscle strength. So this was her X-ray when she came in. You can see we did some 3 views, and the lateral view shows an obvious anterior spurring, which frequently happens with a lot of sports players. They get stretching of that anterior capsule from certain, plantar flexion effects.
Yeah.
Her articular surface, although congruent, does look a little bit irregular on the medial aspect, and there was some higher suspicion for OCD to that area there. So the MRI came back as we expected. There was osteochondral dome lesion to the medial talar dome, measuring approximately 2 centimeters in length, with areas of sclerosis, cystic change, 1.1 centimeter loose body versus partially attached fragment, and a little bit of arthritic changes with some narrowing of the joint, and deltoid changes, as well as ATF and CFL sprains present.
Yeah, not fantastic in a 17-year-old.
Exactly. So So, with these procedures, I know we're taught to adhere to certain guidelines for size of lesion and things of that nature. But what I've learned through experience and is, giving these patients a chance to heal on their own, especially youngsters, is always going to be my first line. But I always preface it to the patient and their family and say, hey, listen, some studies should suggest that the larger the lesion, we may have to do a more aggressive or a different treatment plan for the defect. But hey, if it's me, I'm doing the cleanup, I'm seeing how well my body can heal, and then I can always go back and repair that defect. However, if we fix the mechanics, if we fix the joint impingement, we get that bone healed, sorry, if we get that area that's damaged repaired or at least debrided so that there's some fibrocartilage that can form, it's worth
Mhm.
a try. You're not really burning any bridges. Whereas if you jump to an oats or some other bigger procedure, you really can cause a lot more damage. And I've
Yeah.
gotten away from doing debridement subchondrally, and I'm just doing abrasion plasty, where we're just exposing a little bit of that raw bleeding bone and letting your body heal now. And I think there's some tendency to go in that direction nowadays.
Yeah. Which is interesting. We can dive into that maybe on a different time where we can spend more time on it. But I've been microfracturing for a long time. I've never had any issues. I know some of the newer stuff is saying that microfracture is causing some issues, but I've been doing it for a long time. Maybe I'm not going as deep as other people. I'm just kind of penetrating, like you said, right through that subchondral bone because I do want to stimulate some healing. But I think there's kind of starting to form two schools of thought about microfracture versus no microfracture. So time will tell on that.
Yeah, so I know we're getting a little ahead of time, but basically what we did is we usually do all these all arthroscopically, and we do an inside out approach. So we first scoped her joint, looked around, addressed the defect, and there's some pictures of the actual what we found when we got in there. You can obviously a ton of people have this hypertrophic synovium at the syndesmotic recess from all that hypermotion. Clean that
Mm-hmm.
up. You can see the defect here. You don't always see it as a lifting piece. Sometimes you have to take a probe and explore it. And then as we cleaned up the synovitis, many times we'll use a RF1 to kind of cauterize it so it doesn't regrow again or
Mm-hmm.
cause a scar band. And then we took down the anterior medial spur formation on the tibia and debris. That's a picture of us showing a burr, removing that hypertrophic spurring. And you can see the clean cartilage there. Then we address the loose body, remove that. Um, and there's pictures of that showing us removing it with hand instrumentation.
These are always wholly disappointing to me because you look at it on scope and you're like, my God, this thing is gigantic. And you pull it out and it's like this tiny little wafer. You're like,
Yep.
what? That's that thing? That thing was huge on the screen. And you pull it out and it's this tiny little thing. And it just feels a little anticlimactic. But yeah,
I love
sometimes
asking
they
the
look,
fellows how big they think it is,
yeah,
and then I'll have them measure the probe, like the distance of the probe, the tip of the probe, and then I'll say, okay, now put the probe in, and you tell me how big it is now, and they're always surprised about I misjudged that one.
yeah, yeah. You get used to it with time though.
Yeah, so this is us doing the microfracture. We're just doing the debridement of the sub of the cartilage and the subchondral plate, and this is us putting the canal in for the anchor site. Where I've switched over to an all suture anchor now, but back in the day we are using biocomposite anchors.
Right.
Then we use a suture passer through the portal sites, and we're passing the suture that we place in the fibula through the ATF ligament at different locations, one anterior, one posterior, inferior, and then percutaneously exiting at about the CC joint or where the extensor retinaculum is estimated to be at. We draw all these lines out pre-op so we avoid the nerves and we avoid the tendon, and that way we can kind of see where we're exiting. And in this picture, you can see our landmarks, and that's important. So this picture in the middle is us rethreading or passing the suture from inside out technique, exiting where we anticipate the extensor retinaculum is, and we usually use two sutures, one inferior, one superior. That way, we capture both parts of the ATF ligament.
So you're doing an arthroscopic brostrum essentially.
Exactly, yeah. Yes, and then we usually pass these through these little portal sites distally, and then tie them and advance the extensor retinaculum and the ATF ligament structures back up to the fibula, thus advancing the the ligament. And this just shows you the progression of how we pass them and exit percutaneously through the the extensor retinaculum there.
Yeah, biggest complication, like you said already, is nerve involvement. If you're going to be passing things somewhat blindly underneath the skin, you just want to make sure that you're not potentially involving the nerve to pass your suture through that, and that's going to cause some nerve issues.
Right. And here, and you see how these are passed and how we've demarcated all the bad areas to stay away from. And then we
Hmm.
passed it through one or two of the puncture sites distally. I used to make an incision here. Now there's the hole's big enough that you just pull it with a probe and kind of tie it down accordingly.
Hmm.
So my post-op protocol, this is an older slide, but it used to be the first 1 to 2 week compression bandage. Sometimes we'll do a nerve blocks for my scopes so that it relaxes the muscles distally, and that way they prolong pain relief. I've had some, I don't know about you, but I'm getting a little bit more like post nerve block nerve pains more frequently.
I stopped. I stopped doing all popliteal nerve blocks. Anesthesia was doing my popliteal nerve blocks. I stopped doing them altogether because they were having this transient neuritis that was just lasting months longer than the surgery would have taken to heal.
Yeah, I agree. And now eventually most of it goes away, and but nowadays I'm doing gabapentin post-op just to help prevent that. But
Hmm.
either we do the nerve block to help relax the muscles, or I'll do a paralysis with my scopes so that way that can relax the muscles so I can get into the joint easier.
Yeah.
We'll do a period of non-weight bearing just until the nerves wake up, and that way the muscles start functioning again. They can support the body weight, and then we'll do weight bearing it about 48 hours later, or 24 to 48 hours later. Then we see them in the office. About 2 weeks later, take any stitches out. We start dorsiflexion, plantar flexion, range of motion, caution with inversion, but we get them moving right away. The problem with scopes of the ankle is that there's a high potential for adhesions, uh, hypertrophic repair that your body tries to heal. And so you got to get these things moving right away. And there's studies that show that early motion helps with collagen formation and orients the collagen properly. And then we started 3 weeks at PT with proprioception training, cautionary inversion, but everything else is pretty much a go. And then keep them in an ankle brace at that point, and then move them to sneakers by up to around the 8 week, 6 to 8 week mark with either a brace, and then eventually getting out of the brace, maybe using it just for occasional sporting activities.
Hmm.
Is that kind of what you're doing with your repairs?
Yeah, I mean, I vary it based on the patient. If I'm doing younger athletes, they're begging me to start practice yesterday. And so sometimes I cave to advancing a little quicker. Depends on if I'm doing just a scope, if I'm doing a lateral ankle stabilization, if they have perineal involvement, if I'm doing an OCD, whether I use minced juvenile cartilage inside the cartilage lesion. It kind of depends on the little technical details, but basically most people are pretty reasonable of limiting their activity. And I'll say, maybe 1 to 2 weeks, we'll kind of start some weight bearing in the boot and then kind of advance your activity. I've been surprised, especially with these 15, 16, 17, 18-year-old kids, how quickly they're able to bounce back from these multiple, scope, rostrum, perineal, plus or minus OCD repair. They're bouncing back really quick.
Yeah, I agree. And this protocol is also for older people in my book too, because same thing, first of all, they have a harder time staying off of it, but more importantly, I think it's that biomechanics that help with the orientation of the healing fibers. And as long as
Hmm.
you can trust your repair, it's strong enough, I think it's a good option. If you're doing it all arthroscopically, open sometimes takes a little bit longer because you're invading more tissues. So the
Sure.
incision heals really nicely. You can see it's very minimal, very little bruising.
Yeah.
And so this is the post-op x-rays that we're looking at right now. You can see that the anterior spurring is significantly resolved. You can see a little bit of remnant of the canal where the anchors are. I also did a deltoid with her too,
Hmm.
arthroscopic deltoid repair. You can see that
Hmm.
little hole in the medial mal that we did the anchor there.
If
And
you do,
those, go ahead.
go ahead. Oh, sorry. I was gonna say, if you do deltoid, are you just doing anterior tibio-talar?
Yes. So
Yeah, me
just
too.
because your risk areas are isolating you to just superior to the posterior tibial tendon and just inferior to the saphenous area. So
Yeah.
you have a smaller window, and you're not doing horizontal puncture through the skin, you're doing vertical. And that way you're not impinging any of the tissue or hurting any of the vital structures there. So you can see the puncture incisions there, and she's doing real good at 2 weeks. 3 months, she's progressing nicely. There's been no bone regrowth. I always check for bone regrowth at the 3 month mark.
Hmm.
Very rare to happen. But if you immobilize these patients who have had scopes, they're gonna have tightness. They're gonna have adhesions. The one thing I will tell you is just got to keep moving aggressively, and that helps with the OCD repair too.
Anytime I do exostectomy or bony resection, this one's a little different because you did it through the scope, but anytime I take bone off, I usually put bone wax on it to prevent bony regrowth. Do you ever use any bone wax or anything on a osseous resection site to try to prevent regrowth? This one's a little different because it was done arthroscopically. That'll be a little tricky to get that in there, but what are your thoughts on that? How often do you see bony regrowth of an exostectomy site?
I don't do that anymore. I used to do it as a matter of like theory,
Hmm.
and now what I'll do is especially if it's arthroscopic, I'll take the RF1 and I don't want to say burn the front of the bone, but I'll
Yeah.
cauterize the front of the bone. And that I think at least prevents the bleeding growth.
Yeah.
And remember, you're removing not only the spur, but you're removing the capsular attachment there. And people think that this impinges and that's what causes the spur. But there's studies that show that these sports injuries are from traction, not impaction.
Hmm.
So a lot of this, soccer players, it's not dorsiflexion injuries that cause these spurs. It's the stretching of the capsule from plantar flexion that pulls on the capsular tissue and slowly creates that bone growth attraction spur, not necessarily an impaction spur.
Interesting. Good point.
So she's 3 months out, doing great. A negative draw, negative tilt, good muscle strength, and she's back to no crepitus anymore, and really very little pain in her joint. I would say sometimes you get these patients and they have a little bit of adhesions if they've been babying and they haven't been doing their exercises. I'm not opposed to doing a post-op cortisone shot just to break up any scarring or adhesions.
Hmm.
But frequently, if you have a patient, everything looks good, and if you have some continued pains or problems, I've rescoped these patients, especially if they've responded to a short-term nerve block or a joint injection block, and they have good relief of pain, but it comes right back. Sometimes they've developed adhesive bands and adhesive scar tissue.
Yeah. How often are you doing uh, pure, what would you call it, abrasion of the osteochondral defect slash microfracture versus implantation of some sort of minced cartilage product or industry product to help regrow cartilage?
Yeah, I used to do a lot of that minced cartilage, and I found that you would want to immobilize them a little further. You'd want to offload them a little more, just so that you're not disrupting that initial phase of the adhesiveness to it. I've never had as good success as when I just do the abrasion plasty to start with, and I always
Mm.
reserve, no matter what size it is, I always reserve the minced cartilage or the allograft. For revision work. And
Mm-hmm.
so I found that my revisions have gone down with just doing the abrasion plasty compared to the puncture through the subchondral plate with a pick. I've really gotten away from that. I don't do that anymore whatsoever. I've never seen the cystic, I've gotten post-op MRIs. I've never seen cysts get better as a result of that. Really, just the abrasion plasty has shown much better success rate in my hands. Now,
Mm-hmm.
again, had a rare occasion where the patient, needed a revision, but that's where we would add that extra tissue, the growth. And as long as you fix the mechanics with the lateral ligament repair, those defects don't get injured again, or they're not getting beat up as much.
Yeah. I do tend to jump to the minced cartilage as a primary procedure, and then, in the back pocket is always an oats or a more invasive, all the other things that you can
How
consider
long do you
that come along
immobilize
with
them
it.
for, though? You got to immobilize them a little bit.
I'm pretty aggressive. I've done quite a few of these minced cartilage on high school athletes, and I'll keep them off of it for 10 to 14 days or so. Range of motion right away. I want range of motion, non-weight bearing range of motion right away. But after 10 to 14 days, I'm letting them walk on it in the boot. I don't know, you know, I
Have
don't
you
know if that's the
rescoped
right.
some of these before, or have you seen how it looks afterwards?
I would love to.
I mean, just coincidentally, not as a rule of thumb, but
Right.
coincidentally.
Luckily, I haven't needed to. They've all been successful. I haven't ever needed to go back and rescope, but I'm sure it'll come at some point. But I
Yeah,
would love to get in there and selfishly look at it and see it.
yeah,
And a lot of times I get the post-op X-rays. I mean, I've had some that look perfect after like 3 weeks, and you're like, wow, that was quick. I mean, the X-ray looked terrible to begin with. You get in there, you fix, and the X-ray looks completely normal after 3 weeks. So it just seems to work better for me. I don't know. I don't have any issues with the microfracture. Again, I'm not going very deep. I'm just putting an all AWL for anyone listening, all down maybe to like the tip where the gold disappears. So maybe just a couple of millimeters. I'm not penetrating way down deep into the bone. So maybe that's the difference, but it seems to work well for me. So
yeah.
I think there's a lot of different
But
routes where
15
we can get
years,
to the
15-year-olds heal anything, don't they?
exactly. Exactly. A
Yeah,
lot of different routes where we can all get to the same destination. So I think that's what makes these things interesting is saying, look, well, how do you do it? How do you do it? How do you do it? And there's probably multiple ways that can get the job done. So really interesting cases there. I appreciate your time and hopping on with me tonight and going through this.
thank you.
Yeah,
Yeah,
absolutely.
yeah, if you have any questions about my we have our website, OCFLA .net, and you can get information about our fellowship. I'm also somewhat active with that 15 Blades. I know you are too.
Hmm.
That's been a pretty cool way of sharing ideas and experiences. So I really appreciate the time that you're letting me present some of the cases and talk about, all the cool mentorship that we're doing and fun stuff. And I just always love giving back to the profession. So it's been awesome doing this. So thank you for this opportunity.
Yeah, absolutely. So if anyone wants to reach out to you, what's the best way to do that? LinkedIn or website, or how would they do that?
You can try me on my LinkedIn account. I'm there periodically. I have three teenagers at home, so it's sometimes difficult for me to do every website. And I'm an old guy right now, so I'm not like on it all the time. But my website is ocfla.net, and we have a link to our fellowship there. And there's my application as well as my email is on there. My email is dr.belis at ocfla.net. I do some Twitter, not a lot, but I also do some Instagram. I'm not as versatile as some of your other younger guys, but it's just because it's just hard for me to do every single social media thing.
It's a
But
lot.
we try to keep up with all you young folks.
Absolutely. So thank you so much for hopping on tonight.
You got it. Thanks so much.
All right. Thanks
All right.
everybody for joining us. I'm Jeff Dikis, and this is Paw Patrol. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.